Hello, everyone, and welcome to today's webinar, DSM-5 TR Cultural and Person-Centered Assessments with Latinx Populations. Today, we're joined by our speaker, Dr. Roberto Luis Fernandez. We welcome you all today as you keep joining in. If we can go to the next slide, please. Firstly, we'd like to acknowledge this presentation was prepared by the National Hispanic and Latino Mental Health Technology Transfer Center under a cooperative agreement with the Substance Abuse and Mental Health Services Administration. And you'll see that all the material appearing in this publication, except that taken directly from copyright resources, is in the public domain and may be reproduced or copied without permission from SAMHSA or its authors, but we do appreciate citations for the sources. So we'd like to note that the MHTTC network uses affirming, respectful, and recovery-oriented language in all its activities, including this one today, as well as in our products and as we deliver events. We believe the words matter, and we use strength-based language to build individuals' existing resources, and instill hope and show a path forward. So a few housekeeping items before we begin today. If you have any technical issues, please individually message me under Eric Senior in the questions section at the bottom of your screen. If you have any questions, answers, or comments for the speaker when we get to our Q&A section, you can please address them by writing in the questions section again. So at the bottom of the screen, so that we can use it to interact with you all. And there's a handout for this presentation, which I'll be sharing or already have shared, and you can find in your handout section. And that's free for you to use now or in the future. Our next slide, please. So a bit about our today's presenter. Dr. Roberto Luis Fernandez is a professor of clinical psychiatry at Columbia College of Physicians and Surgeons and director of the New York State Center of Excellence for Cultural Competence and the Hispanic Treatment Program. He's also the co-director of the Anxiety Disorders Clinic at New York State Psychiatric Institute. He's a lecturer on global health and social medicine at Harvard University, and he led the development of the DSM-5 Cultural Formulation Interview, which we'll be speaking about today, and which is a standardized method of cultural assessment for use in mental health practice, and the principal investigator on its international field trial. Well, with that said, we like to welcome again our speaker and let him off for the presentation.
Thank you very much, Eric. It's a pleasure to be here. I'm going to cover a fair amount of material. I will try to do it clearly, and mostly what I think in the interest of time I will need to do is to summarize each slide rather than necessarily go through every bullet point. Sometimes I'll mention some bullet points more than others. But you should have access to the slides, so that's good. You would have the full, the full content, even if we don't touch on every single point. As a takeaway, the topic of the talk, the purpose of the talk is to argue that ways that culture patterns mental health problems should be included in psychiatric classification systems and in the person-centered clinical assessment. I'll do that by covering these points: limitations, a definition of culture, how it was addressed in DSM-5 and DSM-5 TR, and then some conclusions. But first, I wanted to explain that in some ways, descriptive psychiatry is considered, at least by some, to be in something of a crisis, because there is a need for a classification system that combines multiple needs, not only for clinical use, but also for research use. So there's some research concerns about the validity of the DSM classification and the ICD, which is the alternate international classification of diseases. They're very similar in their descriptive approach, that is to say, being based on referencing signs and symptoms, things you can ask people about and see, as opposed to what's happening in the brain or in the mind or things like that, which is a different way of approaching psychiatric classification. This descriptive approach, some people are having trouble with, and one main area that it has trouble with is that it seems to not be as useful for reproducing the entirety of the person's experience. It is an acknowledgedly limited approach that takes the superficial characteristics and the person's own experience to a certain degree, but it's more in the shape of the form of the tradition of the conditions rather than the context in which the situation is happening that might explain why the condition arose, or necessarily the brain structures or psychological structures that underlie these presentations. That's the debate. To what extent does a descriptive approach capture all those elements, and can it ever capture all those elements? And some people argue, well, it was never really intended, DSM is never really intended to be a complete description of the totality of experience, or it isn't meant to necessarily reflect brain findings. And other people argue that without those kinds of echoes and connections, it may not be very useful. One position that a lot of people in the working in classification take that may be different from how it is perceived in its use in clinical practice of the classification system, of the nosology, the DSM system, is this problem of reification, which has become a major concern by the biological psychiatrists, and it also has been a concern for the more socially minded, anthropologically minded, sociological minded psychiatry and mental health people in general. And by what I mean by reification is the mistake of assuming that the category that is described in the manual is the disorder, as opposed to a limited representation, a picture, a sketch of a disorder that we don't fully understand, and which is always embedded in social worlds, and which is always unique to the experience of the individual, and which always varies from place to place due to a million social, cultural, etc. characteristics of humanity. So this is illustrated here by this painting, which is a famous painting by René Magritte that says in French, "This is not a pipe." And it's not immediately obvious if you're somebody who takes pictures seriously, why is this not a pipe? But for somebody who looks at it as a picture of a pipe, it's quite obvious that it's just a picture of a pipe. It's not a real pipe. And in that sense, that's the same debate with the categories that are in DSM. Are they the real thing, or are they just a poor picture, as good as we can make it, given the limitations that we have describing these experiences, of an experience like that? So the critiques are that this decontextualizes the disorders from the mechanisms and the experience of the person, and a number of other critiques that have been levied against this diagnostic system, which results in the overall critique that perhaps what's in the manual, what's in DSM, may be over-specified, so it's missing, variants all over the world, it's too schematic, and it's decontextualizing. So it's not a very thorough understanding of the person's experience. It's just a sketch of a pipe, basically. So to try to address this, to keep both the descriptive, reliability-based, criteria-based assessment of DSM, and to increase its validity and decrease its overspecification, DSM attempted to do a number of things, like DSM-5, like in 2013 when it came out, to increase the dimensionality of diagnoses, to incorporate neurobiological data, to clarify the relationship between disorders, individual disorders, and other disorders, and with the clusters in which of larger structure of disorders like spectra. This is what was called comorbidity, or is called comorbidity. And then these last three things, which I will focus on, about incorporating symptom variation, about clarifying the relationship between ways of expressing distress, which are always culturally based, and providing tools for assessing context of illness. These were ways in which DSM-5 tried to improve on this reification, crisis of descriptive psychiatry, difficulty with validity issues that I was mentioning, decontextualization that I was mentioning before. So the idea is I went through these bullets and I mentioned that I would be focusing on these 3 bullets here at the end and in the red box. And then I am now specifying what was done to do those general goals for DSM-5. These were the places in DSM-5 where the cultural group that I led for the manual introduced cultural material, if you will, in the introduction, definition of mental disorder, criteria, text, and in this section at the end of the DSM-5 on a cultural formulation approach and a way of understanding the relationship to cultural concepts. And in DSM-5 TR, which is not a revision of the criteria, only a revision of the text. DSM is divided into criteria, which define a disorder, and text, which explains, gives information about it, but the TR versions of the DSM are just for updating the text. So we added elements to multiple parts. Some parts stayed the same of the manual, including more sections on culture and social determinants of mental health. And then we made some changes here for on those sections of the cultural formulation section to improve the coverage, the integrity, if you will, the way the whole chapter worked together, and made some changes to make sure we reduce non-inclusive language. So what is culture? Let's start there to get on the same page, because it's important to have a similar understanding of what it is to understand what we tried to do in DSM. Culture is a difficult word to explain, and I will try to do it briefly, because in the US and in many parts of the world, culture is understood often as synonymous with ethnic or national background, as if there were very homogeneous groups of people in different parts of the world, all of whom behaved or thought similarly. And while there are collective elements of culture, a way of understanding, it's also very highly individualized. So, a person will interpret their own culture and create culture anew every day and in every generation, every single moment. And that a better understanding of culture is to have a process-based understanding where culture is the way in which we make sense of the world and we behave in the world according to that sense that we make. So it's really not a set of propositions or values even only, but rather the whole process by which these propositions, values, social structures, ways of laws, religions, every which way that humans create as a form of understanding the world, how all of that is put together. So by the same token, culture, therefore, as a process, is based on the relationship a person has with their background, groups of origin, and throughout life. So culture is affected, if you will, influenced by one's age, the neighborhood one lives in, the family one grows up in, one's gender, one's sexual orientation, national origin, race, ethnicity, religion, occupation. A number of things all influence how you make sense of the world. And that is what your culture is. And of course, people who inhabit similar places will have certain things in common because of their common social characteristics and traditions. And you don't make this up every generation. You inherit traditions that then you revise. And so there's a collective and an individual aspect to culture, and it's a process rather than a static set of characteristics. So it's always been this way, and there's a risk of thinking of it otherwise, because then it becomes reified again. It becomes a thing that one is supposed to adhere to, as opposed to a process that changes, which can have very healthful aspects and very unhealthful aspects. There are traditions that are not kind to all of us, as has been said, and that need revision and rethinking. But of course, this is part of the process of making sense of the world, that is the property of people and groups in trying to do that. And therefore, when you try to assess somebody's culture, you can't just look at them and say, oh, they come from such a place, they must think like this. You don't know that. You have to actually engage people to know what they think, what they do, how they feel. And the complicating element always is that it's very hard to ask a simple question, what is your culture, and get a useful answer, because this is a very difficult, out of consciousness thing. Most people take for granted that the way they look at the world is the normal, useful, usual way of looking at the world. And so, like this idea of the fish may not know they're swimming in water. We have to, as clinicians, we have to engage the person to understand how the person looks at the world, basically. So I won't go through this. The DSM-5 and then 5 TR glossed, explained this way of looking at culture through a series of bullets that are included in the introduction in the cultural formulation interview section, a description of what the DSM concept of culture is, which is basically what I just explained. And then this slide is here to remind me to talk about disparities, because there are many disparities in social life in every part of the world, the US, where I work especially. And the attempt of trying to understand a person's culture, cultural understanding, their background, their social context in which they live, the structural aspects of society that influence how they live and how they make sense of the world. Paying attention to these elements may be a way, and it's an object of study, to reduce disparities, for example, in quality of care. Not all differences are disparities. This is from the Institute of Medicine definition. Some differences are just because people use services more or less because they need it more or less. If there's a difference that is due to an appropriate, some conditions are higher in some groups than others, then that's a legitimate difference. But if there's a disparity is when the difference is unfair, due to unfair reasons, basically. And I won't go into more detail. If you want to talk about it, we can for sure. But the idea here is to remind the discussion that a cultural assessment and an understanding of how context impacts the diagnostic process may be a way of reducing disparities, which are very common in terms of misdiagnosis, misapplication of severe forms of treatment, lack of access to particular types of treatment versus others. For example, lack of access to psychotherapy because of money. This is a disparity that is very prevalent in most parts of the world, if not everywhere. Things like that, racism. So I wanted to then cover, again, because of time, relatively briefly, 3 parts in which the DSM changed in order to adjust for increasing contextualization, decreasing over-specification of diagnosis, to increase the role of context and variation and person's own experience around, how it varies around the world in the DSM process. And one was to make sure wherever possible that we incorporated symptom variation that happen in different people, parts of the world, sectors of society, genders, include all this in the DSM list of descriptors. For example, here is under criteria, and the question is the list of panic attack symptoms complete? Does it capture what a panic attack is everywhere in the world? And the answer is no. It's an okay list. It works okay in many parts of the world, but there are symptoms that are not captured that are important in certain groups. For example, this is work from my colleague Devin Hinton among Cambodian refugees in Massachusetts. And if you ask them about open-endedly about symptoms of panic attacks, essentially what is an acute anxiety attack, you discover that they discuss symptoms that are unusual for the DSM, such as ringing in the ears, neck soreness, headache. These are very common. You see them in red. These are the bars represent the frequency of the symptoms as reported by 100 Cambodians spontaneously. Cambodian refugees in Massachusetts. You want to make sure to point that out. It's not every Cambodian everywhere. It's in a certain context in this particular clinic. But you see how there are symptoms that don't appear in the list. that are tied together by certain ideas about how the body works. For example, in Cambodia, it's quite common to think of, to understand illness as related to a gas-like substance called kayal that can move around in the body creating symptoms. And similar in some ways to the way Puerto Ricans speak about gases, for example. It's an old idea about a movable sort of subtle substance, as it's called. And so that ties together the idea that it would produce tinnitus when you have an anxiety attack. There's an ethnophysiology understanding. So this just says that the symptoms that are in the manual are useful but not complete. And after a lot of debate, this was in the committee I was in, this was the compromise that we came up with, which is not changing the criteria, but adding a note that says there is variation, but you shouldn't count it as one of the symptoms. This was, you see how, as they say, the sausage is made, how it's a complicated process where people give opinions and eventually you reach some level of compromise. So you're not, describing nature as it is, you're describing reality as you see it, and this is the best we could do. Another question was, what about cultural variability and the risk of onset of PTSD after you're exposed to trauma? This is actually, there's been a fair amount of work on that. And here are data from Florida after a hurricane back in 1992 that looked at a difference in PTSD symptoms, self-reported, by level of exposure to hurricane-related trauma across ethno-linguistic groups. That's a mouthful. Let's see if I could say it again. But the idea is that the x-axis is level of trauma, the horizontal axis, how much trauma you're exposed to during the hurricane. The vertical axis is what % of the sample met criteria for PTSD due to self-report. And you see that when the trauma is low, there's very little difference in risk of PTSD by ethno-racial group and ethno-linguistic group, in this case, white, black, and Spanish-speaking Latinos in Florida. But as trauma rate goes up, you see that the Spanish-speaking Latino group has more PTSD. This is after adjusting for a lot of factors. So what you see when you look at the reasons for that, you find that it has to do with an external locus of control among that Spanish-speaking Latino group, and it's an association, an intersection between locus of control and ethno-linguistic group, and also whether you're exposed to acculturative stress. These are migrants in Florida. They must have, the ones with acculturative stress were more vulnerable to the traumatic experiences of a hurricane. So you see how PTSD doesn't just happen to everybody the same way. It depends on your prior experiences, on your understanding, as in Cambodia, of how the body works. All these things are related to the risks for disorder and should be considered when you're making a diagnosis, because you need to understand to what extent the condition may meet the criteria. It may be a picture of a condition may be similar, but the mechanisms may differ, and that may have to do both with what you focus on in psychotherapy. For example, here you might explore the external locus of control and the acculturative stress and so on, and also how severe, how much stress the person has to be under to develop the symptom, and therefore how severe it might be and how intractable it might be to treatment. So of course that's related, but they're not equal. It doesn't always mean that severity means intractability. But so you have to explore all of these things. So what we did in this case in DSM-5 was add a number of things. Here's the fatalism, the external locus of control, the acculturative stress. These were added to the text and in DSM-5, and then for DSM-5 TR, more of these kinds of variations were added to the text. A second point that I wanted to talk about in ways in which DSM-5 and 5 TR incorporated this cultural question is, what is the relationship between cultural concepts of distress, the way that people express, understand, embody distress, and these diagnoses in the book? How are they related? And first, I wanted to explain what I mean by cultural concepts of distress. Everybody in the world, including psychiatrists, express distress in their own way. You know, psychiatrists, I spent 30 some years working on the DSM. I'm obviously, you know, exposed to it, influenced by it. It is very likely in my enculturation as a psychiatrist that if I express panic attacks, I would express them influenced by what is in the manual that I've studied for so long. But everybody in the world, whether it's the manual influencing a psychiatrist, or it's a family member influencing a child, or it's a grandmother influencing somebody, you know, or your religious affiliate, there's always influences in how you understand what's happening, and therefore what aspects of experience you pick out, and also how you experience them. So you will, for example, Cambodians, it isn't like they experience the same panic attacks as other people. They may experience ringing in the ears, tinnitus, more perhaps than other people because of the affiliation of that notion of that gas-like substance, wind-like substance they call it, and panic and anxiety in Cambodia, you see? And so there's these ways that people express. We speak of nervios in Puerto Rico. That's a whole concept of distress that has many, many aspects. There are many others. If you're influenced by religious traditions, you might speak of, you know, being attacked by spiritual forces. Any number of ways in which the experiences that you bring color, characterize the experiences of the suffering that you have. So these are all described in these different texts, including in DSM-5, and this is true of everybody. For example, right now, it isn't just the othered people, you know, the minorities that talk like this, or the uneducated, it's everybody. That's why I gave the example that me as a psychiatrist, I would be influenced by DSM because I'm influenced by what I've known my professional life. For example, in the US at the moment, and I suspect elsewhere, there is this great focus on the concept of burnout. It's not that burnout isn't real, it's that burnout is a cultural concept of distress. It comes out of a particular moment, a certain, you know, the impact of the pandemic, a certain relationship with work, you know, late structural, post-structuralist capitalism. There's many ways in which burnout is being created by the current moment, and there's a general understanding of what the symptoms of burnout are, what the causes are. This burnout was something that happened before, but it wasn't something that we discussed and noticed and labeled a certain way. This is how cultural concepts come about, if you will. And so one cultural concept that's very common in the Latino world is that of ataque de nervios, which is a fit of acute emotionality in which a person feels like they're out of control. And it could be any number of emotions, fear, anger, grief, and it's essentially a sign of being overwhelmed, usually after a stressor, and usually indicating the difference, the gap between what they've suffered and what they can handle. And most ataques, many ataques, I should say, it's unclear exactly if it's most, may be normal. They just happen under severe circumstances. And then if the circumstances get better, they may not return. There is a lot of epidemiology on this. I won't go into it in great depth. There's a variation in prevalence across Latinos in the US. Puerto Ricans have the highest percentage at 11%. In the island of Puerto Rico, it was between 13 and 15%, depending on whether they met criteria for a psychological distress disorder or not. More common in women. There's a number of reasons for this. The idea being it's a way of expressing distress. And I'll show you, you'll see the picture. I hope you can hear the sound. If not, let me just preface by saying this is an ataque captured on a phone in Santo Domingo Airport after the crash of an airplane in New York heading for Santo Domingo, in which the man in the video has just heard that his family, his brother, has died on the plane, and he has an ataque. And you will see, notice how the man reacts, and also notice how the people around him don't freak out. They essentially surround him, contain him, support him, in a way, as you know, you can take from this that they're not completely, it isn't like they don't know what this is. You know, they are aware that the man is having an extreme reaction to a bad event. Here it is.
Santo Domingo Airport seems to have grieved for the loss of so many loved ones. This man was one of those who'd come to meet relatives or friends for looking to be sold, they would never about 175 passengers were from this Caribbean country. So my daughter said it can't be. My mother had heart trouble and had all children. I kept looking at my brother. He was on the plane.
You see the situation of the attacker. Brother dies on the plane. The man has this reaction, fearing for the health of his mother, who will have a heart attack upon finding out that her son has died. So this is a kind of reaction that is common, 5 to 10%, 5 to 11% among U.S. Latinos, higher in Puerto Rico, that has a certain symptom frequency. This is the work of Peter Guarnacha and other colleagues, Vivian Febo at the University of Puerto Rico, Glorisa Canino, a bunch of people who did this type of analysis where you ask people in Puerto Rico about their first ataque de nervios, and they spontaneously report these symptoms. So there are some of the symptoms of ataque are fit in the list of 13 symptoms of the panic attack list of criteria, symptoms in the criteria. Others less so. Some of these still qualify about losing control. I put it separately because it's a major focus of importance to the definition of ataque. There are also dissociative symptoms that are, some of them are in the panic list, others are not. Lost consciousness is not, amnesia is not. And then there are anger and aggression symptoms, suicidal symptoms. One in every first ataque has led, one in every seventh first ataque has led to a suicide attempt, and other symptoms as well, like this man crying, screaming, so on. So you see how it's a syndrome. It's symptoms run together. You ask people about it, you get a common understanding of what it is. It's not in the manual. So what should be the relationship between that category of experience and the diagnostic systems, syndromes? And one way that we recommend to think of this is that it's an alternate way of experiencing suffering that can be connected to the disorders, but there is in the DSM, but there is no one-to-one relationship. It's not like ataque is always panic attacks. Sometimes it is, and sometimes it isn't. In a study that I did here in New York City, about 36% of ataques fulfilled the full diagnostic criteria at the time for panic attacks, and 17% for panic disorder, because they don't meet certain criteria. They don't have some of the symptoms, or they last too long, or they're they're never unprecipitated, different things like this that are requirements for panic attack or panic disorder diagnoses. They vary, right? But there are other conditions that could be diagnosed, that an ataque could be diagnosed as. Sometimes they're more dissociative. Acute dissociative reactions are considered ataque, or trauma reactions, or neurological conversion type symptoms, or even intermittent explosive disorder, or they're normal. Sometimes ataques at a funeral, in the old days particularly, were considered normal. The person it's a grief reaction, loss of control at the graveside, for example. This isn't a pathological condition necessarily if it doesn't lead to any sequelae or so on, or impairment that is any more than a little while. So you see how this is an orthogonal category. And every cultural concept, if you will, is an orthogonal category to these more distilled, boiled down, schematic elements that are in the DSM. They all start out as these more full-fledged, fuller, complex presentations that then get schematized. And that was the purpose of the professional activity of creating the nosology. But you can't use the nosology as if it was the reality, like that idea of the pipe, the real pipe and the picture. You have to use the nosology as a picture of a pipe. It's a suggestion of the sort of things that it might be that you would want to consider, because knowing that would lead to particular kinds of outcomes. So this is why there is no ataque category as one of the specified categories in DSM, because it falls under these specified categories. But what happens when there isn't a category in the manual for which the cultural concept is pointing, then we have to create a new category in the manual, which is what happened when we realized that the DSM, unlike the ICD, doesn't have good categories for acute dissociative reactions. The DSM focuses on chronic dissociative reactions, whereas ICD-10, 11 has both chronic and acute dissociative reactions. So one of the changes in DSM-5 was to add more examples of acute dissociative reactions, because those had not been included in the manual before, and the cultural concepts point to that kind of nosological gap, if you will. So another, here's a point about the final point about the usefulness of cultural categories. Why do we care about the cultural categories? Because the cultural categories convey information that is very, very useful to treatment. Here is one instance, there are many, one instance of the kind of information that they can be conveying. If you take the National Latino and Asian American Study, this is the Latin American part, which is a representative community-based sample epidemiological study in the US community, not among patients, but in the society, testing, asking about disorders, psychiatric mental health disorders. You find that the presence of having, saying that you've had an ataque de nervios at some point in your life, after adjusting for many, many other possible causes of these outcomes, saying you've had an ataque gives you twice the risk of disability, suicide ideation, and use of outpatient mental health care. Just saying you've had an ataque, which means that the ataque is a marker of severity. It's a marker of being overwhelmed. You can understand that the person has had a bad experience that leads them to have this outburst of loss of control. That's a marker of possible further severity. It might be through the dissociative mechanism, it might be through some other mechanism. So you see how the usefulness of these kinds of concepts, but how it's a different language that is not necessarily captured, is not captured by the psychiatric diagnosis. You have to do both, if you will. Finally, as a set of tools for dealing with this, the DSM wanted to propose a series of a way of operationalizing a framework that had appeared in DSM-4 about what should be taken into account in a sociocultural contextual assessment. And what that is a process of organizing and using information on the impact of culture and social context in order to, for the person and their social network, in order to use it in care, basically. You wanna understand the person's context, their own understandings of things, their own behaviors in terms of how they think of it, how they do what they do about it, in order to incorporate that in care. And we're always doing that, whether it's you do it ad hoc, you sort of unconsciously make these assumptions about people, or you actually do it systematically. We argue doing systematically is better. And a systematic assessment should follow these essentially steps. So it should work in this way. It should be comprehensive in the sense that it covers all the important material, should be thorough, so each point is handled in sufficient depth. It should be standardized, so you actually can do it, remember to do it, not forget anything. You can learn it. It should be skills-based, so that you don't depend on being a certain kind of identity. It's something you can learn how to do regardless of your match with the person. It should be person-centered, so you really want to know about that person's understanding, contexts, culture, not some stereotype of the person. All men, all women, you want to know about that man or that woman or that, a queer person. And then educational, you want to learn from it, you want to apply it, use it, get better as you go along with using these assessments. There are 4 basic uses of a sociocultural assessment: to gather more information that is useful for clinical care, to actually impact the exchange so that you improve communication, engagement, patient empowerment, to train yourself and other people in how to do this kind of assessment better, how to not look at the DSM as the true reality, but as a schematic that is guiding you towards something, and how to look at context. You want to train yourself and to train trainees in doing, but you also want to remember how to do that. And you also want to use it to implement change in how to enhance the chances that a person will get good care, socioculturally informed person-centered services. So what is the cultural formulation interview? That is one thing I've been mentioning as a possible assessment. It's a set of interview protocols. There's 3 of them. I'll cover them in a minute, that can guide cultural assessment during evaluation and treatment planning. And we argue it can be done with any patient, any person seeking care, by any person providing help in any healthcare setting. There are 3 parts to it. There's a core CFI, which is what I will go through now in a minute, which is the questions you can ask directly of a person seeking care. There is the informant version, which is questions you can ask a companion of the person, either for additional information or because the person is too sick, too young, to something to provide the care themselves, the information themselves. And then there are supplementary modules that expand. If you want a more thorough, comprehensive assessment, you can expand on each of those answers. We did this field trial for DSM-5 in all these different countries. I'm very proud of that because they did it for very little money. Everybody did for very little money. This is what we were operationalizing. It's the outline for cultural formulation that appeared in DSM-4, and it's a way, there it was, and it's still in 5 and 5 TR. It's a framework, a narrative framework for what should be part of a cultural formulation assessment. You should explore cultural identity, for example. You see the 5 points on the screen. What CFI does is answer the question of how do you explore cultural identity? What kind of questions should I ask? And that's what CFI provides those examples. So in order to do that, what we did, we followed a process for the DSM-5. In 1994, in DSM-4, this outline, this framework had come out, and in between 94 and 2013, when finally DSM-5 was published, people had been working on it. So they had created interviews, questionnaires about how to operationalize a outline for cultural formulation from DSM-4. So we gathered those people, we created a brief version of the CFI, we developed a training approach, we did a field trial in all these places, we've been analyzing it, and all that led to the creation of a final, so far, 16-item core CFI that's in DSM-5, and we continue to work on. Now, how to use it? We think it can be used with anybody. As I said, we recommend it be used at the beginning to get the person's perspective, to guide the care in general, but it can be used at any point. And particularly when there's any question or concern or mismatch in the understandings between the person and the provider, or structurally the system isn't providing adequate care, the person is not feeling met or engaging or empowered. So you can, there are many ways in which you can use it. The ones in blue were mentioned in DSM-5. The ones in brown that has to do more with systemic issues were mentioned in 5 TR. But these are just examples of when you can use it. You could use it at any point. This is what it looks like on the page. On the left in italics are instructions. This is what the question is for. So if the verbatim question on the right doesn't work, you can reword it. Or if you don't, you want to reword it from the beginning. And then the questions in the right column have the column has introductions and probes and questions, and I will go in domains, and I will go through those in a second now. So these are 4 domains. This is the first of the 4 domains. We want to know, with the cultural definition of the problem, what is the problem that is being brought to care? And at the end of this domain, the clinician should have a phrase that they will use to identify the problem using the person's own language. So if the person says, you know, I'm really upset because my son went back to jail, you don't use the language of major depression, unless that's the language the person uses. But if throughout the conversation the person is, I'm just really upset, I'm really suffering, I'm having a very hard time, those are, because my son is in jail, I'm very worried about him, those are the words that you use. And you create a phrase, you know, what is the cause of the fact that you feel so upset about your son being in jail? You know, that some question that uses the phrases the person uses, because experience near language like that has been found to be much more associated with empowerment, engagement, satisfaction, and so on. So, and of course, along the way, you can improve on that phrase. If you discover as you do the interview that you get a better sense of what the problem is, then you can keep incorporating that better phrase as you go along. But what you're trying to get at is the causes, the uses of care, the fears, and so on, that the person has about what they think is going on, not what you think is going on. if you will. That this part of the interview is about what the person thinks is going on and the social network and their community, if you will. So that's the first domain. This is the first domain in more detail. There's an introduction that normalizes the situation for people. It says that they are the expert. We want to know. There are no right and wrong answers. We want to help. The first, these are the three questions. What is it that's bringing you to care? How would you describe this thing to people in your family? Because we as clinicians, we never ask this question. We want to know, you're telling me it's schizophrenia. What do you tell your grandmother it is? Because that actually really helps understand the range of meanings and context in the family. And then what is it that bothers you the most about it? Because we want to focus on what bothers them the most. This is the first domain. The second, and this asterisk signals that this is the first of the three questions in the core CFI that involves the social network. That's the first domain. The second domain is, why is it happening? What makes it better or worse? And what is the role of cultural identity in this process? It has those three parts. Here they are. First, what causes it from your perspective and from that of your social network? This is the second place where the social network comes up. And it could be any kind of cause. It could be supernatural reasons. It could be physical illness, problems at work, being laid off, something horrible, that some form of discrimination, trauma. These are all possible answers. You want to know them, right? The second domain is what made it better and what made it worse. This is one place where structural factors can come in: money problems, access to care or education or work. The third domain is the one about cultural identity. This is a hard one to ask. We've worked hard on this. It can always be improved. There's a fair amount of focus on this section. The idea is it's hard to explain what culture is in a few words. So we want to know about background or identity. That's how we frame it. And we give examples, but it could be other forms of background or identity. In one case that I use a lot, Atlantic region in the US, their main background or identity was that they were a homeowner. They were hospitalized. They had worked 30 years to pay a mortgage. If they didn't get out of the hospital and pay their mortgage, they would lose their home after all that time. So being a homeowner was the main element that they were concerned about affecting their situation at that moment. And that's, it's not race, identity, faith, whatever. It was, another one is being a veteran. That's another one that came up a lot. So you see how you ask, what are the most important aspects of your background or identity? What do they make any difference to your problem? It may or may not. And then are there any other concerns regarding cultural identity? I'm illegal, for example. It may have nothing to do with my current problem, but it's affecting everything else, that I'm an undocumented migrant, for example. So that's the second domain. You see where we're going. We're trying to understand the person's context, own experiences, the views of their social network and community. The third domain has to do with what have they done in the past to cope with this problem that is defined by them, what they've done on their own, what kind of help was helpful, what kind of help they sought, what was helpful, not helpful, and what got in the way of obtaining help. Here's another place where structural issues come in. The third domain is then, what do you need now? And you ask two areas. One is, what do you think? What is your perspective on what you need? And what does your network think you need? This is the third and last place where the network comes in. So what care preferences do you have? That's the first domain of this section. And then the second domain has to do with the relationship with clinical services. Are you concerned in any way about the relationship between you and me, or me and the clinical service? And you'd be surprised. This question varies a lot by setting. There are some settings where it's a little bit hard to answer, maybe intrusive. And in the setting in Queens, in which we've done some work, 55% of patients, this is a very multicultural setting, 55% of patients in that hospital in Queens had an answer to this question. That had to do with fears of discrimination or past experiences where doctors didn't understand. It was very present for them. So it may depend on the kind of sample, if you will, the clinical work in which you work, clinical world in which you work. So that's the CFI. What's it good for? I covered before. I was going to spend a little time, and I'll spend just a few minutes describing each of these a little bit more. in terms of gathering better data, you just get a lot of information on the person's views and the person's context. You really understand their stresses and supports better. You clarify the words, the text, the understanding they have, the words they use, how they embody their conditions when you ask them for their own explanations. It enhances communication and rapport, so you get better data. You understand their expectations of care, and so on. So we have some data that shows from Denmark, Mexico, and the US, many parts of the world are working on using this because of its centrality in DSM. It had an impact in many places. And they find in general that the treatment plans are enhanced after the CFI with psychosocial therapies as opposed to just medicines, because you understand the person's situation better, and alternative treatments, not just biomedical ones. And I don't have a lot of time for this one, but just to say that the cultural formulation more generally may have an impact on diagnosis. And I'll leave it at that, in the sense that these are data about using a cultural formulation approach that's not quite the CFI. It's more, it's different, but it's all based on the cultural formulation model. And in McGill in Canada, they found that nearly half of the patients that were referred to a cultural consultation service for some problem that the clinicians thought were psychosis, nearly half were re-diagnosed as not psychosis after spending more time with the person and understanding their context and cultural background more. Many of these people were refugees from South Asia that had been exposed to trauma. It ended up being dissociation, misunderstanding of idioms of distress, rather than psychosis. So it may be useful for diagnosis as well. The second area is that it tends to improve the engagement, the way in which communication, rapport, participation take place. Here's the example I gave you about patients being able to state in the first visit that they were either mistrustful or ambivalent about clinicians, because one just asks them about it. They felt good enough at the end of the interview to report that. Or we have some evidence from a study in the same place that shows improved retention at 3 months. We're about to be funded. So far, it appears 95% to be happening, to pursue this in that hospital for longer with more people, about a possible engagement effect of asking people that they stay in treatment as opposed to leaving treatment, asking people about their expectations and understandings of care. These are data from qualitative studies that show self-reflection, self-validation, and so on. And when you ask people, these are data from the field trial, when you ask them what you think of these questions right after they've had the CFI questions and the rest of the diagnostic interview, these are answers from clinicians and patients. In general, they're similar with slight differences. Patients think it increases rapport, it evidences caring. Patients are, clinicians think they get the perspective better, it enhances communication. But you see how the general idea is most of people found something very positive to say about the interview. I'm almost done in terms of time because we're running out of time. But another importance is the value of thinking for training of using these assessments is that you train yourself to see the person in a context rather than just the diagnosis or the intra-physical or in their body, or their mind only. You try to put them in a history or a moment, a place, and all that positionality, their resources and constraints, their relationship with health systems. There's so much of this that is beneficial from trying to see the person in context. And it's a much better way of training than just providing stereotypical information about, the Asian patient. The Asian patient, Asia is like half of humanity. It's not possible to have a 1-hour lecture on the Asian patient. You can give some general ideas, but you always end up close to a stereotype. This idea is another way of doing that kind of training. And there are better ways of training, like there's this very nice 3-hour case discussion seminar that's been studied at McGill that produces some documented impact. There are even brief approaches that show a positive effect on cultural competency scales, all based on the CFI. but more work is being, is always being done on this issue of training. We have a training module, which is available in English around the world here through that website. So you will have this information with the slides. So finally, about systemic change, the idea is that this provides information, provides a method for conducting socioculturally informed, person-centered services. We find that we did implementation type research during the field trial. It can be done in a short period of time. It doesn't have to be done in 20 minutes. You can take more time, but it can be done. Patients like it even more than clinicians. The clinician concerns decrease with use. So it's actually possible to use it, including even for program development and evaluation. The references are all below, but we need more research. We always say that. So in conclusion, I hope I've shown you that the DSM process tries to reduce overspecification and decontextualization, but it's difficult because we are tied to this criteria-based nosology, which is very prescriptive. It has its reliability advantages. It's under question for its validity possibilities. That's always been for 30 years or more, 40 plus, 45 plus years at the moment. This has been debated. There is a value to sociocultural assessment in recontextualizing evaluations and eliciting person-centered information. You can use the CFI to do that. It always needs more work, but there's some evidence that it may help enhance quality of care, possibly even overcome disparities, and we need to keep working on it. So I'm going to turn to a few questions and answers as I realize it's almost time's up, and I believe you need to complete the evaluations. But Eric, do you want to open? Are there any questions in the chat or anybody who wants to?
Yes, thank you, Dr. Lewis. I'm going to first share for you all the evaluation code, and while I do that through the chat, please feel free to add any questions you may have for Dr. Luis Fernandez. This evaluation is important for us and our funders to make sure we can continue delivering such presentations as this with other resources and speakers, which are so intriguing, so enriching. So thank you. Let me
I want to emphasize what Eric has said. I want to emphasize what Eric has said there. It's very important that you provide an evaluation because that way this can continue, because they need this empirical information to show the funder that it's having an effect or not, depending on your evaluation.
Yes, depending on the evaluation, but we really do appreciate you joining us today, Dr. Lewis. The information and the content you bring in terms of the descriptives and the differentiation between descriptive parameters for diagnosis is so intriguing, but at the same time, so a practical use for providers to understand when reading the manual, understanding the manual, engaging with patients through the CFI as well. So let me go ahead and check the questions tab here. Is the CFI assessment available in Spanish?
Yes.
That is one first question. Yeah.
The core and informant CFIs are available in Spanish. The way this works is that the APA sold the rights to the translation to the Spanish publisher. So you have to obtain it from the Spanish publisher. It's in the hard copy, the text of DSM.
Thank you. So I've shared the survey link through the chat if that's easier for you to check. One comment for the speaker: I would just like to thank the speaker and the NHLMHTPT for this terrific presentation. It's extremely informative. Thank you. Can the website be shared again on the cultural competence information?
Sure.
Thank you.
Let me. I think you mean this one.
I'm pretty sure that's the one our audience member is referring to. Thank you, Dr. Lewis. Thank you for your presentation, Dr. What are your recommendations for future research?
And you want me to say that in one sentence? Uh, the the idea is that we have a pretty good idea of the components of an assessment, but what are its effects? Exactly, you know, we have some beginning, but what is the, how much of an impact does it have on patient satisfaction, on patient's improvement, on you know, time in treatment, on cost, on any number of things that are important in this capitalistically organized healthcare system for producing this kind of change? How can you convince people providing care of the usefulness of this? That's one set of research studies. And the other, another set is, are there better ways of doing this? This is one way of doing it. Are there better ways? And another set of approaches is, okay, say it's useful and say it's the best way or a good way anyway. How can you implement it? What kind of strategies can you use to encourage its use? How should this be paid for example? Should there be a billing code? Should we expand the initial interview time? Because it's if we you know, if we do it all at the beginning, we have a better outcome near the end. We save a ton of money from people getting better and not, you know, dropping out too soon and having to be readmitted to the hospital. So all these kinds of implementation questions also come up.
Thank you, and I'll try to address maybe one or two more if we can get through them. I understand that Hispanics and Latinx is a large cultural group. Does the DSM consider the subcultures within the Hispanic population, Dominicans versus Mexicans, etc.?
The DSM process is quite aware of this difficulty. The issue is what kind of data exist to actually what kind of data exists that the DSM process considers sufficient to make statements in the DSM as to changes to the DSM based on these differences. Because although we all know there are differences all over the world, it isn't just Latinos who are different, but there are differences among other groups as well. The issue is has there been enough work on each one of these to put them in the manual without actually stereotyping? Dominicans are like this, you see, and so you have to actually weigh that rather carefully, and that was part of the process that went into DSM-5 TR. But it isn't like it's perfect. What I'm saying is, yes, it's an issue. We are well aware of it, but the data needs to be in a certain form, epidemiological rather than qualitative, all sorts of things that the DSM requires in its traditions.
Thank you, Dr. Luis Fernandez. I guess we'll have time for one more question and then we'll have to close out. The comment is, I'm really excited about this work. Do practitioners really believe that this doesn't compromise their diagnosis? I would imagine in a broader sense, the content that was presented today, the information.
I think, I don't know, but it's hard to speak for all practitioners. but I think what people are concerned about mostly is the amount of time this takes. And the fact that they have a way of doing a simple diagnosis that is pretty good, you know, it's not that bad type of idea. And so why would I spend so much more time? And you know, they want me to see 100 patients an hour. How am I ever going to do that? It's not against asking these questions much of the time, as much as that's all very nice, but maybe I can afford not to do it. You know.
Well, thank you,
Doctor.
And thank you all for joining today. We also admire your work as practitioners or those who are in the mental health field. The workforce is much needed for Hispanic and Latinx communities, so we appreciate it and thank you all. You will get an attendance certification for this webinar, and as I said, the handout is in the handout section, so I'll leave it open for another 30 seconds. But until then, thank you, Dr. Luis Fernandez, and we hope you will have a good day.
You too. Thank you very much.
Bye.